Okay, so I'll start from here. A patient attends an emergency appointment with a fractured twin block appliance. You take an appliance alginate impression and send the appliance for repair to your dental lab. You're concerned because recently several appliances which have been replaced do not fit properly, and this may be due to polymerization shrinkage. So if there's more shrinkage, so you add more powder. So use polymer powder and monomer liquid. Use monomer liquid only. Use monomer liquid and light cure. Use polymer powder only. Use polymer powder and light curing. So it's more polymer in the liquid, right? The liquid should be there. Without it, it's not going to, effective. Okay, there's the lag. So I think because there's another question too. So there should be more polymer powder, right? But without a liquid, there won't be a reaction. So that's the point here. So I think this question, like people have modified this question later on. So there should be more powder along with the liquid.
So A option is right.
There's no good option here. It should be use more polymer, right? It's just a polymer powder written here. So it should be more polymer powder or increase powder liquid ratio. Because a powder alone cannot have this reaction. Being an orthodontist, it is impossible to be aware of different aspects of research in order to advance. Which of the following element of research does generalizability dependent upon? Efficient didn't get the question. I don't know if it's a question of the exam or not. Which type of the following studies cannot be considered observational studies? Prevalence of missing lateral incisor, relationship between gender and growth, incidence of malocclusion, effect of different bracket system on incisor tract, relationship between TMD occlusions, option D obviously here.
Hello, Dr. Harris.
Yes.
Doctor, I have an inquiry for the first question about the polymer and liquid. Dr. Saba said it's option A and it was marked option A. If it was written use of more polymer powder with monomer liquid, is it possible? Then
Yeah,
we
there
choose
should be
it?
more powder or increased powder
Yes,
liquid.
sir.
Like
Okay, so if
if
you
we
use more
see,
powder along with the monomer liquid, it's fine.
yeah,
Okay.
you cannot like would use a monomer liquid alone or a polymer powder alone.
Yes, sir.
Yeah, basically
I
the
want you
powder
just to
liquid
verify for
ratio.
me. Increase the powder liquid ratio. Okay, thank you,
Yeah.
sir. Thank you.
Also, light curing to some extent also decreases than the conventional. But like the
Yes, sir.
none of the option is correct here. The one that are given to us here.
Okay, thank you, sir.
So a 14-year-old patient underwent gingival recontouring of incisor. The carbonized tissue was left over the incisor. Which solution should be used in this carbonized tissue? So hydrogen peroxide or sodium hypochlorite. Sodium chloride is not option. Just give me a sec. Okay, should be hydrogen peroxide, 3%. Option C. A 19-year-old male presented with mandibular asymmetry, his chin seems to be deviated to the right side, and there was
Oh,
also marked centerline shift and a cross bite on the contralateral side.
Dr.
But no,
Harris,
it
can
was
you
a
share
pen. Sorry.
the screen? Can you share the screen?
Okay.
Also, if you can return back to the previous question regarding research question, is it D or E?
This one, it's D
Research.
here.
No, effect.
Yeah, because they asked that cannot be a observational study. So here in the option D,
Okay.
we are not going for observation.
Okay, thanks.
So 14 years patient underwent gingival recontouring, that is 3% hydrogen peroxide. And then here, 19 years presented with mandibular asymmetry, his chin seems to be deviated to the right side, and they also marked centerline shift and a crossbite on the contralateral side. Usually the chins are always deviated toward the same side. Just give me a second. So, and a crossbite on the contralateral side, but no occlusal canting. Which of the following statement is correct? So it's a hemimandibular elongation. The patient's scintigraphy would demonstrate increased uptake on the right side. Yeah, so his chin seems to deviate to the left side, and there is also a marked centerline shift and a crossbite on the contralateral side. What is this? So the crossbite is the affected side. Ideally, the centerline shift should be also toward the right side, not on the left side. So there's a crossbite on the left side, so I'll select the left side with the scintography. The patient's skin would demonstrate increased uptake in the left condyle. Yeah, I select this one. Because in hemimandibular elongation, the chin deviates toward the opposite side, and so is the midline many times. So, yeah, option A here. A class 3 patient with normal upper and lower incisor inclination and good profiles presented to you in the orthodontic department. You are planning for non-extraction treatment using class 3 elastics. Which of the following torque specification will be used? So the upper and lower incisor inclinations are normal. You are using a class 3 elastics. So it means that we have to prevent the retoclination of the upper lowers. A patient with normal upper presented to you are planning to do non-extraction using class 3 elastics. See, if I'm trying to do a class 3 camouflage, right? I need, inclination changes. So if they are normal, I will try my best to keep them normal, because the effect of class 3 elastics are that they propline the upper incisors and retoclines the lower incisors. So it means that for the upper incisors, if they are proclining, I have to give a low torque, and for the lower incisors that are retoclining, I have to give a high torque. So low torque uppers and high torque lower, option D here.
Sir, please explain this last question.
So you are using class 3 elastics. So what are the effects of class 3 elastics? Yes, Dr.
Procline upper and retocline upwards.
Yeah. So the inclinations are normal. You want to keep such inclinations. So to prevent the inclination increase in the upper, you keep a low torque on the upper. And to prevent a retoclination in the lowers, you increase the positive torque in the lowers. So a low torque in the upper and a high torque in the lowers, like increase positive torque. So option D here.
Sir, like the side effects of, we want to reduce the side effects of class 3 elastics.
Yeah, we want to maintain the normal inclination of the incisors. We try our best.
Okay. Sir, but in a camouflage, we will not appreciate option A.
Why option? We
Like this
intentionally want to
is a
apply it.
non-extraction case in a class 3 skeletal, they probably asking about a camouflage.
Yeah, but we do not intentionally want to proclaim them.
So how will it be then negative, like incisor class 3
The incisor will
incisor
go more boldly then.
relationship will be correct.
The incisor will go more
Body.
boldly then. If you keep a positive torque along with procreation, so it would be more procreation of the incisors, right? Along with the mesial movement. But if you keep this torque, the torque is basically root movement. So you would have some bodily movement of the incisors rather than tipping.
Okay, sir. Like a main reason of selecting all these are like a good profile is present. So we don't want to change that.
It's a class 3 camouflage, obviously. If they're using elastics, it's a not camouflage, or even it's not a camouflage. We try our best that it shouldn't proclaim them. They have just given the upper limits. The upper incisor inclination should not exceed more than 120 degree.
Yes, sir.
Right. Like you are not aiming for 120 degree. It should not
Sir,
exceed the 120.
but it's sir, but they mentioned normal. So when we camouflage, we have a range that we can proceed from it. It's not an ideal case.
No, we do
Like we
not
are
aim for that,
camouflaging
doctor.
it.
No, we
We
don't
will.
aim for that. It automatically happens, but we do not aim for that. Like if I'm camouflaging
Okay.
a class 3 case, I aim that my incisor inclination should not exceed more than 120 degrees. I'm not aiming they should become 120 degrees.
Okay, sir.
Like that's why I want bodily movements. Like when you use this class 2 elastics, you give -6 torque, so the incisors in growth modification of fixed functional appliances, they come forward bodily, right?
Okay.
Because the effects of
Thank you,
these
sir.
appliances are that they procline. So our aim is to do that minimum possible proclination.
Okay. Like the when we give a positive over torque in lower and
Yeah,
negative in upper, so it will compensate the side
proclination.
effects of class
Yeah,
3 and will
yeah,
do the positive.
yeah. And the tooth will
Okay,
move
sir.
more boldly.
Okay. Thank you.
Dr. Harris, in the question of mandibular asymmetry, here you chose option A, right?
Yeah.
I mean, what would be the diagnosis? Either if they're thinking of elongation or hyperplasia, because
No, they
if
are
it's
not thinking of
elongation, then
hyperplasia.
chain.
See, it's occlusal
Yeah,
canting.
sorry.
There's no occlusal canting. So when it's no occlusal canting, it's not a hyperplasia.
No, but in elongation, chin and centerline moves to the opposite side to the.
Yeah. So number one, it's not hyperplasia, right? So now it's elongation. So in elongation, the chin deviates toward the opposite side. The center line also deviates toward the opposite side, and the crossbite is on the affected side. So the center line thing is not given right here, right? So rest is all the features of hemimandibular elongation.
Dr. Harris can't hear you.
Yeah, because I was disconnected.
Okay, sorry. So I was saying that if it's the case of elongation, then a chin and center line had to shift to the contralateral side.
Yes,
But here they are saying that chin seems to be deviated to the right side and center line to the left
that's
side.
a mistake in the question. That's what I said previously.
Okay.
Otherwise, you
Okay.
cannot solve
Okay.
this question.
Yeah, this is what I'm thinking.
Yeah.
Okay. Thank you so much, sir.
So they are asking about the IoTN. So he has a class 2 div 1 incisor relationship on a class 2 scuttle base and reduced vertical proportion. There is a fully erupted supplemental upright side. Fully erupted supplemental. So we have one supplemental tooth. The OJT is 9 millimeter, so that is also 4A. And overbite is complete to the palate and traumatic. Okay, that's also in the 4 range. This left side is scissor bite affecting the premolars and severe lower arch crowding with a contact point display 4.5 millimeter. And the lower left lateral incisor and canine. All permanent teeth apart from third molars are erupted. So, what is IoT in dental health component?
4A.
Yeah, the OJT is the biggest component here.
Dr. Harris, are we done with this question?
Yes.
Can I please go to the two questions back? I am sure it is going to be an inconvenience, but I really have that doubt on incisor talks in class 3 camouflage situation.
Yes.
So here, could you please just let me know that you have chosen lower incisor talk, right? Or high?
I
As
choose
in D
high for the
option you have
lowers and
chosen,
low
is
for the
that
upper.
right? So in the telegram it says you have chosen D. So
Okay.
D is high talk in the lower. So I'm
Yeah.
getting terribly confused. I'm sorry. I don't know it is
Yeah.
from
This I
my
choose.
side or
Yeah.
what. So are you agreeing on high talk in the lower?
Yeah. Need most positive torque in the lower.
So when we camouflage a class 3 case, I need more retroclination of the lower incisors, right?
Yes.
So that means I should go for negative torque in the lower, right?
See, the effects of class 3 elastics are due to inclination of the lower incisors and proclination of the upper incisors. Right. The inclination in this case
Okay.
are normal. So when you give the elastics,
Okay.
the teeth will tip backward anyway. You like or not, they will low incisor will tip backward, upper incisor will procline. So you will counter them to some extent.
Okay. Because the question says that they were normal to begin
Yeah,
with.
like because we do not do class 3 camouflage a lot, but we do fixed functional appliances or class 2 growth modifications a lot, or class 2 elastics a lot, right? So that's why I
Hmm.
have given the example that for fixed functional appliances or class 2 elastics, they use negative torque in the lowers. Because when we are giving these class 2 elastics or a fixed functional appliance, it means that we are trying to decrease our overjet, right? So if I carry the same concept forward which you have, then I should give a positive torque on the lower incisors along with class 2 elastics, so they should close the overjet. But we are not doing that. We are giving negative torque, we are giving MBT brackets.
Hmm.
Just a
Okay.
second.
Thank you so much. Sir? Hello?
Yeah, just give me a second. Yeah, sorry. So what's the other question?
Dr. Harris, if
Yes.
we take this question in terms of class 2 case, so it would be the low torque in the, sorry, high torque in the upper and the low torque in the lower, right?
Yeah, that's what people are doing. That's why people are using the MBT brackets. If you go this book for systemized orthodontic treatment mechanics, one of the main reason for making this prescription was class 2 elastics, extensive use of class 2 elastic, especially in United States,
Yeah,
because they were
yeah.
giving negative torque. They were also decrease the negative torque on the lower molars because of the effect of class 2 elastics, and due to the retoclination of incisors due to the effect of class 2 elastics. So you simply reverse the concept on the class 3 cam flash cases.
Okay, got it. Thank you.
And what's the other question, Dr. Sheikh?
No, Dr. Harris, thank you so much. I just had one question. Thank you.
Okay. A 12 years old patient attempts to start orthodontic treatment. You had previously requested the dentist extract the upper and the lower second molars to allow eruption of the unerupted second premolars. When you examine the mouth, you see the dentist has removed the first permanent molar in error. You believe that, okay, they are lax. You believe that you can still achieve a good, but still take a longer. What is the most appropriate way to manage the situation? Write to the dentist not mentioning that the first molar has been removed and ask for removal of the second primary molars. Dentist not mentioning that the first molar have been removed. No. Inform the patient and the parents that the dentist has removed the wrong tooth, but that you believe that you can achieve a good result, then contact the dentist. Yeah, this is the right option B. Speak to the dentist, ask them to inform the patient that they extracted the wrong tooth. Say nothing to the patient, but inform the dentist. So I think option B here. Okay. I think I have lax, like, yeah, a very extensive lax. Ten-year-old boy reported to orthodontic department with the chief complaint of crooked, irregular teeth. After a thorough examination, it was recorded that the child has a habit of thumbs-upping vigorously for 12 to 14 hours. It was also noted that the child has a V-shaped maxillary arch and proclined upper incisor and retroclined lower incisor. The position of the lower molar inside patient is, we have decided that it should be buccal. People have their own articles, but it should be like the last option. 1, 2, 3, 4, 5. E. Yeah, for this tooth, we decided that we can do a window technique because there is a lot of attached gingiva there.
Not partial thickness. It's partial thickness, doctor.
Steve is an adult male who has diagnosed with HIV 15 years ago. He presented you with class 2.
Dr. Harris, you hear me?
Sorry. Yes, Motas.
It's partial thickness. It's
Sorry.
partial thickness. It's above the. It's partial thickness. It's above the lateral incisor.
Yeah, but do you believe you can do a window here?
Yes, we can.
If you think you can make, if you think the gingiva is here and you can make a small window here, then you can go for the window technique. Right. It's about the attached gingiva. The lateral is slightly inward. So if you think it's a movable mucosa, so do you think it's a movable mucosa? Because I see the boundary here for this one. So I think I can make a window here. Yes, Motas. No, like it's not a
But
root.
Dr. Harris, they have written also that 2 mm of keratinized tissue is present above the canine.
Yeah.
So it means it's 2 mm above.
Yeah, so if it's a so it's attached gingiva. So window technique. Steve is an adult male who was diagnosed with HIV 15 years ago, represented with class 2 intermediate in size relationship, half unit class 2, more relationship bilaterally, and amically prognathism. After examining Steve, you dispose of your gloves and face mask. In which colored waste bin you will dispose of the clinical waste? Yeah, so which one? I think they are wasting all their steam into the orange steam. No, orange is for generalized. In the yellow, they did steam. But I have to check for this. I will update you on in the WhatsApp for this one. I have to check for the. I think it's a one with the yellow. Orange is for the general waste. Black is for the domestic. So it cannot be red. It's not contaminated. I think it's yellow. Because for the dentist, like everyone say that they have only one with the orange steam and one with the yellow lid, right? In the dental office, they do not have other steams which are specialized in the medical sides, or might be with the maxillofacial surgeon like cytotoxic and cytostatic products. So I think that would be yellow. A patient presented to you with a mild class 3 skeletal profile. He has compensated incisor and you aim for non-extraction camouflage treatment. What you will do? Okay, so this question is different. He has compensated incisor. So what does compensated incisor means?
Procline incisors. Procline and retocline. Lower
Procline upper
procline.
incisors and retocline lower incisors. So again, like if they are procline, the rule will remain the same as using class 3 last week previously. You'll use low torque for the upper, so the incisor shouldn't procline more, and a positive torque or increased torque. Low torque upper, high torque lowers. Option E. What is the shortcoming photograph here? Aperture is small, low. I don't think so. Two system of white balance are being used simultaneously. I don't see them. Low lip was not retracted sufficiently. Yes, to some extent. It was taken from side, no. ISO is large, no. So I think like the low lip, the option C here. What could be the possible mistake? It's taken from the side. ISO is not a problem. Angle of the is correct, yeah. The option C. When evaluating stainless steel wires from two different manufacturers on a stress strain curve, one of the wires shows a shorter distance between the yield point and the failure point, while the others wire the distance is longer. When evaluating quality of two wires, which chemical element affects their property? Usually they say that it's night eye. A. A 11-year-old child was brought to a doctor. His mother was concerned that he frequently injured himself preferred to stay alone and talk very little, if at all. After running some diagnostic tests and taking a complete medical history, autism was suspected. What of the following genetic condition related to autism? So we decided that Fragile X syndrome. It's more cystic fibrosis is also there, but option B. So they are doing a unilateral anterior expansion. I think a similar question came last time in the Gen exam. The following appliance was used to treat the lateral. Even they say that one of the lateral incisor was invert. Treat the lateral incisor that was palatally positioned before treatment. In which of the following situation it was given? So unilateral anterior crossbite. So which side is this? If the picture is properly flipped, it's the right side. Right side unilateral crossbite without displacement. Right side unilateral crossbite with displacement. Bilateral crossbite, left side, left side. So I'll select right side. Let me double check. Yeah, right side crossbite. Option E. What is the first thing you will make sure? Non-latex energy, natural level, no special step required, range of
So in
3.
last question, option B is there.
Sorry,
Last question, option B,
I selected option A.
crossbite,
It should be with displacement. Yeah, option
option
B.
A.
Option B. Option B. It should be with displacement.
With displacement, without displacement.
With displacement. Usually small unilateral crossbites are mostly affiliated with displacement.
Dr. Harris,
Yes.
can you return to the picture?
Sorry.
Can you return to the last question? What the next question? What's the purpose of this doctor?
Yeah, I'm just trying to read it. Which one archway is most preferred to close spaces? So 1925 SS. That's mostly the working wire on a 2-2 slot. A patient presented to your orthodontic facility wearing an upper removable appliance with anterior bite planes. He had received functional appliance therapy from elsewhere. What does the appliance do in this patient? Orthodontic facility wearing upper removable appliances with anterior bite planes. He had received functional appliance therapy from, okay. Anterior bite plane to reduce overbite. Yes. Reduce bite to displacing molar. Reduce bite and maintain space. Help in correction of the lateral open bites. It should be a deep and steep inclined plane, not bite planes. But he said they have received functional appliance therapy. So if they receive, so most likely then for lateral open bites. You are junior house officer for maxillofacial team. While recognizing the theater list, you have asked to check the consent form of the patient who are going to the theater. You realize that the patient who has just gone to the theater has signed a consent form of the wrong procedure due to the mix-up of paperwork. By the time you get to the theater, the patient are ready and sized and the surgeons are scrubbed. Alert the surgeon and theatre staff to the paperwork mix-up, change the details on the consent, discuss the case with dispense, fill in the incident report form, and contact the risk. I think like at this time, alert the surgeon and theatre staff because they haven't done the surgery right now. Barak is 8 years boy, accompanied by his father, and was assessed recently by his GDP on examination. He has grossly low left E, low right D, low right E that are associated infection and pain. Barak upper 3 are not prepared. Opening shoot upper 3 are in sector 3 with the alpha angle of 20 degree. What is your initial recommendation? First, go with the pain and the pathology. So is E 8 years, lower E's left and right side D and E. So he's just 8 years, like early they should be temporized. Restore D and place the SS Hall crown. Extract upper C's, L's, LRD's. Restore the low left E, low right D and E, and place a loop space maintainer with support the upper 6 and the low left E. Why is placing us? Restore low left E, low right D, and low right E, and place SS Hall crown slow. Extract upper C's. No. Extract low left E, like patient is H here. Extract low left E, D, and extend band loop space maintainer. In just restoration, I don't know like what's the correct option here. Do you see any reason for maintaining a space maintainer if you're not extracting anything? An examination has grossly carious that are associated infection and pain. So if they can do a pulpotomy, that's great. Otherwise, you have to extract them. So it's not restore. If we are going
Extract and
to,
lingual arch. Why not extract and lingual arch?
where is the lingual arch?
B and C option.
Yeah, option C then. That can be the only correct option. Okay, I'm going to end it here because I'm having a lot of lags, right? So see you in the evening. Like,
Dr. Harris, will we have a recording of this session, please?
yes, I'm doing a recording, so I will save the recording if it's saved. I'm having a lot of lags.
Perfect.
The VPN is
Thank you.
disconnecting.